Good afternoon, everyone. Today I am presenting the case of acute proptosis with orbital compartment syndrome due to bilateral pansinus mucopyocele, which is an unusual occurrence, management, and its result. I have no financial disclosures for this presentation. Introduction. First, let me give a brief introduction regarding the mucocele. Mucocele is an epithelium-lined mucus-containing cystic lesion, which has the potential to gradually expand and fill the sinus completely. Incidence of mucocele is generally normally 0.4 to 0.8% in general population. It may occur in paranasal sinuses, oral cavity, appendix, gallbladder, or lacrimal sac. When the contents of the mucocele become infected, it is termed as mucopyocele. It may involve frontal ethmoidal sinus, which is being the most prevalent one, then the sphenoidal, and then the maxillary one. Patient may present with the complaints of the displacement of the globe, diplopia, ocular pain, headache, Horner syndrome, or panhypopituitarism. A 37-year-old Indian female came with the chief complaint of forward protrusion of left eye for 1 week and also with the diminution of the vision. There was a forward protrusion of left eye for 1 week, which was associated with intermittent fever, bilateral frontal headache, and mucoid nasal discharge. There was past history of FES for chronic allergic sinusitis associated with bilateral sinonasal polyposis, and there was no history of systemic illness or any ocular surgery or trauma. On ocular examination, the BCVA in left eye was 618, and there was grade 2 RAPD along with the ebaxial proptosis with hypoglobus, and resistance to retropulsion was present. Exophthalmometry showed 28 mm of proptosis. On ENT examination, NDT rhinoscopy showed bilateral inferior turbinate hypertrophy. Systemic investigation showed mild leukocytosis, and CT scan of the orbit showed a heterogeneous mass arising from the left frontoethmoidal sinus and infiltrating the left orbit, which is causing the indentation of the globe as shown by the yellow arrow, and also the tenting of the optic nerve. MRI of the brain and orbit showed peripherally enhancing areas in bilateral nasal cavity, right more than the left, and also in the bilateral ethmoidal, frontal, sphenoidal, and maxillary sinuses. The lesions are seen to extend in both the orbits. Along with in the left orbit, it is causing the significant mass effect on the compression as well as the compression on the extraocular muscle with the resultant proptosis, and in the right orbit, it is causing mass effect on the medial rectus muscle. Coming on to the differential diagnosis, my first differential was pansinus mucopyocele, and the second was fungal mass, and the third was the sinonasal malignancy. The patient underwent endoscopic guided white bone needle aspiration of pus along with the exploration and biopsy. Pus and straw-colored fluid had undergone microbiological examination, which was non-revealing of any microorganism. Biopsy tissue showed mucosa tissue lined with ciliated columnar epithelium along with the scattered seromucinous gland, and along with the mixed inflammatory infiltrate composed of lymphocytes, foamy macrophages, and neutrophils. Now, my final diagnosis was acute proptosis secondary to bilateral pansinus mucopyocele with orbital compartment syndrome. At 2 weeks follow-up, patient proptosis was relieved. BCVA was 6.6 in both eyes, and extraocular movement was full and free in all gazes with the resolution of RAPD. Now, coming on to the discussion, bilateral pansinus mucopyocele is a rare entity, and traditionally mucocele has a slowly expansile nature and presents later in the course. However, in our case, we had acute proptosis with orbital compartment syndrome, and to the best of our knowledge, such kind of occurrences has not been reported previously. Mucocele usually accompanies the path to the least resistance, which often leads to the orbital extension. MRI is the gold standard investigation, whereas the investigation of choice is CE-CT, as it helps us to delineate the bony erosions. Endoscopic orbital decompression should be considered, and primary etiology should be targeted to relieve the intraorbital pressure. Now, coming on to the learning points, mucopyocele paranasal sinus in paranasal sinus should constitute an important differential in a case of rapidly progressive proptosis, especially in with the cases of the history of sinus surgery. Rapidly progressive proptosis with orbital compartment syndrome indicates the development of mucopyocele and needs urgent intervention for preventing irreversible vision loss. Endoscopic exploration and decompression provides
Dr. Khushbu, just sum up. Your time is up, please.
And therapeutic intervention in these cases. These are my references. Thank you.
Thank you, Dr. Khushbu. Dr. Shalu, would you like to comment on this paper?
Yeah, Dr. Khushbu, very nice documentation. Yeah, these cases, mucopyocele usually present to us when they have a vision problem. They have the acute presentation and they neglect the nasal symptoms or this thing. That's why they present late. and their prognosis is very good if the endoscopic debridement is done. Yeah, they do regain their vision, and the outcome is very good in these cases. So the early intervention is must in these cases, and MRI gives us a good clue how to act. It was a good case, and it showed a good resolution.
Yes.
Ma'am, you want to add something?
No, I agree with you. And it's important to pick up all of these cases early. You should, unless the mind is looking for it, you won't see it. So it's good. You must suspect and try to pick it up early so that we can get a good result.